Okay, so I'll be now talking to you about viral keratitis, and we all are familiar with the picture like this, which we see when we stain a case of corneal ulcer with fluorescein staining. The viral keratitis could be because of herpes or could be non-herpetic. Herpetic eye disease could be because of herpes simplex or herpes zoster. This is a case of herpes simplex keratitis. A case of herpes zoster keratitis, which is associated with the dermatology lesions, and a case of adenoviral keratoconjunctivitis. Coming to the herpes simplex keratitis, it could be primary ocular herpes confined to the epithelium associated with blepharoconjunctivitis and lymphadenopathy, or it could be recurrent ocular herpes, which could be infectious, epithelial, stromal. You see the second picture, and the endothelial, the third picture on the bottom. Apart from this, there could be also neurotrophic keratopathy. Now, these are how the dendrites of herpes simplex keratitis look like, and the margins they stain with the fluorescein, which has excavated appearance, unlike the herpes zoster dendrite, which has a more creamy appearance. When the herpes dendrite progresses, then it breaks and forms what is called as geographical ulcer. So if any patient comes to your clinic having this kind of geographical ulcer, you must always ask for history of topical steroids, because in most of these cases of epithelial dendrite, if topical steroids have been given, then the dendrite actually breaks and becomes geographical in dimensions. There could be herpes stromal keratitis, and where the corneal edema would be there, the corneal thickness would be increased, as shown in these two pictures. And apart from the non-necrotizing stromal keratitis, you could have necrotizing stromal keratitis, where there would be perforation, or you can have immune stromal keratitis. You can see the picture on your right side, double immune ring of Wesley, a picture which was taken by Vanathi almost 10 years ago. Necrotizing stromal keratitis is the most devastating form, with heavy infiltration, deep vascularization, corneal thinning and perforation, all of which you see in these three pictures. Herpetic endothelitis, on the other hand, could have a disciform pattern, could have a linear pattern, or could be diffuse. And apart from this, there could be neurotrophic keratopathy or metaherpetic keratitis, which occurs in the long run, which has classically scalloped margins. It can also present as a marginal keratitis. Herpes is a masquerader. It can present almost as about anything that you can imagine, as a peripheral corneal ulceration with underlying anterior stromal infiltrate and adjacent limbal congestion. Generally, we do not send for viral cultures, but we do investigate for herpes antigen. The specificity is only 70%. And other tests are done more for research purposes than for clinical diagnosis. The mainstay of treatment is Acyclovir 3% ointment, and this table actually summarizes the entire treatment protocol of herpes. If you have epithelial keratitis, that is a dendrite, start with topical Acyclovir 3% 5 times a day for 1 week, and then 3 times a day for 21 weeks. If both epithelial and stromal are present, treat the epithelial first. So start with topical Acyclovir 5 times a day for 1 week, and then after 1 week, when you have treated the epithelial part, start with the steroids, spread acetate 2 to 4 hourly, and then taper both by about 6 to 8 weeks. When there is a necrotizing and non-necrotizing stromal keratitis, then apart from the topical Acyclovir, which we'll be using in these cases, and topical steroids, you have to add systemic Acyclovir 400 mg 5 times a day for 1 week, and then 3 times a day for another week. In case of metaherpetic keratitis, one should withdraw the epitheliotoxic drug, give intensive lubricants and cycloplegics, and you may have to give steroids. And sometimes you may have to resort to surgical modalities of treatment such as conjunctival flap, amniotic membrane graft, glue for small perforations, patch graft, and even tectonic graft. And this is amniotic membrane grafting in neurotrophic ulcers in cases of herpes. And this is a case of neurotrophic ulcer where multi-layered amniotic membrane grafting was done. The small piece was put in the center with the help of the sutures. Now you can do it with the help of the glue, followed by a larger piece which helps to aid epithelialization in these cases. And although we did conduct a randomized control trial and to see if amniotic membrane works as well as medical management, and we did not find any difference between the two treatment modalities. Disciform keratitis, one has to give topical steroids and topical cycloplegics, and there may be topical acyclovir toxicity, so one has to stain and stop acyclovir if that is suspected. Systemic acyclovir is given in cases of recurrent stromal or epithelial keratitis, immunocompromised patients, and herpes simplex keratitis in a graft such as this, where you see that there is a presence of dendrite on the graft itself. The recurrence can occur as late as 15 years also post-operatively, and you have to then give topical acyclovir 3% 5 times a day. For prophylaxis, one must always give oral acyclovir 400 milligram PD for 1 year, especially if a graft has been done for a case of herpes, healed herpes keratitis. Coming to the zoster keratitis, it may be acute phase with punctate epithelial keratitis, microdendritic ulcers, nummular keratitis, and disciform keratitis. And these are the differentiating features and the two pictures which show the difference in the dendrite of a simplex and zoster. So simplex has a linear defect, there's stroma, and has an excavated kind of a look, whereas zoster has an elevated, painted kind of appearance, a more creamy appearance, and there is no excavation. And terminal bulbs are present in simplex and absent in zoster. In the chronic phase, you can have mucus plug, neurotrophic keratitis, nummular and disciform keratitis, and treatment is oral acyclovir 800 milligram 5 times a day for 2 weeks, along with lubricants and cycloplegics. And coming to the last part, that is the adenoviral keratitis, which is what we most frequently encounter and which can be really bothersome, especially the nummular opacities, which just don't go by any treatment. It is because of the serotype 8, 19 and 17 of the adenovirus, and one has to differentiate it from microsporidiosis, or one has to suspect even microsporidiosis in these cases, as Prashant told you. In acute stage, one gives cold compresses, lubricants and prophylactic antibiotics. For nummular opacities, some people prefer to give only lubricants, others add topical steroids for 6 weeks, and some others use topical cyclosporin along with the lubricants. Now, with the steroids, these nummular opacities, they go faster, but they also come back faster. With the topical cyclosporin, they take some time to go, but the recurrence rate is slower. But again, there are no trials which would compare the two modalities, and so we can't say which one is better. Thank you for your attention.